Yeah, this is Dr. Caudle Miller, Dr. Miller's Guide in Neurology, and we've been talking about a lot of interesting problems we see in the clinical practice of neurology, and we're going to talk about a basic problem that so many people have, and that's neck or back pain. So neck or back pain are really difficult, and they need to be worked up aggressively after a period of conservative treatment. So, when I see someone with back pain, I ask them, when did it begin, and was there an injury? Is there trauma associated with it? What's the character of the pain? What's the location? Is it just in the center of the back, or does it radiate down the leg? When it radiates down the leg, that's called radiculopathy or radicular pain. Is there any numbness or weakness? Any bowel or bladder symptoms? Rarely bowel or bladder symptoms early on. And what is their treatment history? What kind of treatment have they had? And have they had any previous back surgery or neck surgery? So, when I see someone with back pain, you sort of need to know the anatomy. If pain radiates down the leg to the big toe, that's L5. So that's generally the L4-5 disc. Sometimes it can be a medial disc at L3-4. Radiates down toward the little toe or the back of the leg, that's S1. That'd be the L5-S1 disc. 95% of discs that rupture in the lower back are L4-5 or L5-S1. So we try to treat people with conservative treatment. So the mainstay of treatment for years has been muscle relaxers, anti-inflammatories or steroids, physical therapy or chiropractic. There was a big article in the New England Journal of Medicine probably 20 years ago, 5,000 patients randomized to physical therapy, medical therapy, and chiropractic, and they all did equally the same. So the chiropractors can do a good job with low back pain and neck pain. So we normally, put people on a muscle relaxer just temporarily because it can just make you feel bad. So something like Flexeril, Soma, Valium, Robaxin, Scalaxin, even Xanaflex, rarely Baclofen. With an anti-inflammatory, the mainstay for years has been Naproxen or Motrin. There are bunches of them that people can take: Mobic, Celebrex, Clinaril, NSAID, Voltaren. A 10 to 14 day course of Flexeril or Robaxin with an anti-inflammatory like Naproxen, 500 twice a day, with physical therapy or chiropractic 3 times a day for 12 weeks. If patients fail, conservative treatment, then we get an MRI, and MRI of the lower back, MRI of the neck. If they've had surgery in the lower back, we do MRI with and without contrast, because acute disc won't enhance with contrast. Scar tissue will enhance with contrast. If you go remove scar tissue, it just grows back. You don't need contrast in the cervical spine because the area is so small. And we do an EMG study. If I do an EMG study and stick a needle in the gastrocnemius muscle and there's denervation, that's S1. So I know I need to focus on the S1 nerve root, which comes across L5-S1. And say patient doesn't, have anything on their MRI and it's just mechanical pain, then a long-term course of anti-inflammatories they can tolerate 6 weeks to 6 months, and then we use a lot of anticonvulsants for back pain. For years we've used Neurontin. Neurontin's a very weak anticonvulsant, so if you're treating epilepsy with Neurontin, you need a lot of milligrams. So that would make us think it's pretty weak for pain unless you use a lot of milligrams. But you need to start at low doses and build up. We started 100 milligrams at bedtime for a week, then 100 twice a day for a week, then 100 3 times a day. The biggest mistake I see is people are put on 300 milligrams 3 times a day and they can't take it. Then work up to 3,600 milligrams a day. Wow, that seems like a huge dose. I've even had patients on 4,500 milligrams a day. Lyrica is 20 to 30% more effective, and now that it's generic, you can get it. And we do the same thing, very low doses, 50 milligrams QHS, and increased. Use it 150 twice a day. You can take 300 twice a day. We also use Lamictal, Trileptal, Topamax, Zonogram. So any of the anticonvulsants, and sometimes combine it with an antidepressant for pain. We prefer things like Pamelor or Tricyclics, Cymbalta or Effexor. A combination of an anticonvulsant and antidepressant. So, and then the final thing is you just have to become more fit. It's so hard as you age. For all of us, even those of us that are ex-athletes, you've got to stretch that back out. 80% of the support of the back is from the abdominal muscles. So weight loss, daily stretching, yoga, Pilates. There's great videos on YouTube. Like 20-minute Pilates for golfers is one that I do, and it's something that you know, even at my age, I'm able to do, and it's really helpful. A good physical therapist can give you a good battery of back exercise. You could look up Williams back exercises, a daily stretching program. People hate to stretch, but get down on the floor and stretch. And I tell people, if you're stretching daily, it can take 6 to 9 months to really see the benefit, and that's what makes it difficult for people to really want to continue to do it. But that's back pain. Now, as far as the cervical pain, it's exact same workup. You know, you look for, you know, the same history, pain rating down the arm. You know, the thumb is C6, the middle fingers are C7, so radius down to the thumb, you look at the C5-6 nerve root. We'll talk about anatomy later. Radius down the middle fingers, look at C7. Anti-inflammatories, muscle relaxers, physical therapy, chiropractic. Not better doing MRI of the cervical spine. So what if patients had multiple back surgeries, has a lot of titanium, and the MRI is just not useful? We do CT myelograms. That's what we all did before we had MRI. I remember doing 20 on Mondays and 14 on Tuesdays before MRI. And you put a needle in the back and inject dye, and then CT is no good unless the dye is there. So CT myelograms are very, very useful. So after that, you know, we talk pain management, and pain management is very helpful, but many times doctors just punt people to pain management, not better. Just be careful with a lot of the procedures they're doing. It's a very money-driven profession. So that's neck pain, that's back pain. You can like, comment, subscribe. More later. If you have any other videos you want me to do, I'm trying to put out 2 to 4 videos a week. Just email me and we'll try to put you in line. So more later.